Good evening and welcome. On behalf of Dr. Guy Mintz and myself, Merle Meyerson, we would like to welcome you to the National Lipid Association's The Lipid Panel. So I'm a cardiologist and lipid specialist, as is Dr. Mintz. The Lipid Panel was conceived to be a lipid clinic conference similar to educational conferences held at academic medical institutions. For both those who have these conferences and for those who do not have in-house conferences and colleagues, the Lipid Panel is a great way to review diagnostic approaches, how to interpret clinical findings, and generate therapeutic strategies, as well as find out the most up-to-date information and come together with those in the lipid and cardiometabolic community. In this series, we review common presentations of rare diseases, atypical presentations of common conditions, sometimes even common presentations of common conditions. And we try to cover as many important clinical topics every lipid specialist needs to know. If you have thoughts about topics to be presented, please be sure to let us know. The Lipid Panel offers CME is held on the last Tuesday of each month, except for December, July, and August. All sessions are taped and available for viewing on the NLA website. I'd like to introduce our panelists tonight. We really have wonderful experts with us this evening. Dr. Seth Martin is a professor of medicine in the Division of Cardiology, specializing at Johns Hopkins University, specializing in preventive cardiology, lipids, and digital health. He is at the Ciccarone Center for Preventive Cardiology, where he directs the Advanced Lipid Disorders programs and co-directs the Digital Health Innovations Labs. He also holds many other leadership positions, including health equity at Hopkins, and is a member of the AHA's National Health Tech Advisory Group and chairs several committees. Allison is a cardiology fellow, first year at Johns Hopkins University School of Medicine. She earned her bachelor's degree in engineering at Columbia University and went on to complete medical school at Johns Hopkins, where she first developed her interest in preventive cardiology and internal medicine residency also at Stanford. Dinesh Kalra, MD, is Chief of Cardiology at the University of Louisville Medical Center in Kentucky and is Professor of Medicine and Radiology at the School of Medicine. He's an international expert in multimodality cardiac imaging, preventive cardiology and lipidology, and infiltrative cardiomyopathies as well. His clinical and research interests are coronary plaque regression, imaging by coronary CT, complex dyslipidemias, South Asian cardiovascular risk as well. Peter Libby is a cardiovascular specialist at Brigham and Women's Hospital in Boston and holds the Mallinckrodt Professorship of Medicine at Harvard Medical School. His areas of clinical expertise include general and preventive cardiology, and his major research focus is the role of inflammation in vascular diseases such as atherosclerosis. So Dr. Libby has numerous research awards and Distinguished Scientist Award from the American College of Cardiology, as well as a gold medal of the European Society of Cardiology, as well as a basic research prize in the American Heart Association. So we're thrilled to have this group with us tonight, and we thank the audience for joining us. I'll turn that over to our moderator and get us going. Dr. Martin?
Dr. Meyerson, thanks so much. Definitely have a distinguished panel here. Very excited to dive into a few cases. So we have an ambitious agenda of 3 different cases to discuss over the next hour. So let's dive right in. Thank you, Dr. Allison Peng, for leading the way here with preparing some interesting cases for discussion.
Thanks, everyone.
And thanks to everyone in attendance. I see you have a good, robust crowd tonight. So looking forward to your engagement and questions.
Great. So I'll get started. So with case 1, we have a 58-year-old Black female. She's got type 2 diabetes with an A1C of 11.2%, hyperlipidemia, hypertension, BMI of 30, family history of coronary disease, who's presenting to our outpatient cardiology clinic to establish care after a local presentation in the emergency department for chest pain. So she presented about 1 week ago to the local emergency department. She had a gradual onset of chest pain with radiation down her left arm when she was unloading groceries. It lasted about 1.5 hours. There was associated nausea and diaphoresis. Her family history is notable for a father with an MI in his 70s and a very strong family history of type 2 diabetes. In terms of her social history, she has no smoking history, occasional alcohol use. She eats a healthy, balanced diet, occasional treadmill use. So in the emergency department, her labs are notable for a troponin elevation to 0.76, and the normal is less than 0.3. Her lipid panel on atorvastatin of 80 milligrams shows a total cholesterol of 242, triglycerides of 109, LDL cholesterol of 180, HDL 40, and non-HDL 162. Her LPA is 49. Her CRP is 2.7, elevated from normal. Further workup shows an ECG that shows normal sinus rhythm. An echo didn't show any wall motion abnormalities with an EF of 55%. And she had a nuclear medicine pharmacologic stress test that showed a small reversible inferior lateral apical wall defects. The patient had ended up preferring to leave the emergency department. She felt better, and therefore she was scheduled for close follow-up in cardiology clinic. But since her discharge, she comes in to our outpatient clinic. She tells us that she's had these symptoms of chest pain radiating down her left arm with nausea and diaphoresis twice at rest. And when she climbs the stairs at home, she notes that she has these same symptoms and it gets better when she rests. In terms of her medications, she's on metoprolol tartrate, 12.5 BID, atorvastatin 80 daily, aspirin 81 milligrams daily, metformin 2 grams daily, Trulicity injections. Her blood pressure, she's normotensive with a heart rate of 90. Her ECG in clinic shows sinus rhythm, non-specific T-wave changes. And after we hear all of this story and all of the workup, we advise presentation to the emergency department for coronary angiography. So after presentation to the emergency department, she's found to have multivessel severe coronary disease on her coronary angiography. So over here, you can see her right coronary artery. You can see some pretty severe stenoses over here proximally and in the mid vessel. And then over here, looking at her left-sided disease, it looks like she has some pretty severe disease in her LAD, as well as severe disease in her left circumflex here. And it looks like she has collaterals that supply her distal LAD. So we have a polling question now. How would you handle the initial presentation in regards to evaluation and workup? So I'll give you maybe about 15-30 seconds to finish the poll.
Okay, host, it wasn't working for me, and then I realized hosts and panelists can vote. Okay, hopefully it's working for everybody else. Okay. Give a few minutes to get the responses there. Maybe after we get these responses in, Dinesh, you could start with your thoughts from an imaging perspective, and then Peter will turn to you. Looks like the results are split between coronary CTA and invasive coronary angiography. Not a lot of people agreed with the initial evaluation by the emergency department nuclear stress test. Dinesh, what do you think?
Yeah, so this is, a run-of-the-mill case in some ways. Postmenopausal, obese, diabetic, poorly controlled, having typical angina, and the first biomarkers are quite elevated. I think the normal is generally around 0.03, 0.04. So this is, a genuine, what we call non-ST elevation ACS. So, and from the story, it sounds like it's a type 1 non-STEMI. And, what we've advocated in these people is you've got a normal EKG, you've got a normal ejection fraction. This is your first episode of a non-STEMI with probable underlying coronary disease. And there's certain risk calculators you can use, whether you use GRACE or TIMI risk score or your heart risk score. And what that does is give you a clinical classification of the patient's risk. And then based on that, you can decide if it's a very high risk patient, for example, a GRACE score of more than 130, then we generally proceed to invasive angiography. Or if there's some other features that bother you, like transient ST elevation, if this patient had a low ejection fraction, etc. But if that's not present, then based on the patient preference, you could do a nuclear stress test. I would probably not do a stress echo because she's just having an MI, so we don't like to put people on the treadmill at that very moment. But you could do a pharmacological nuclear stress test or an invasive angiogram. Now, even though I'm a CT expert, there's only one trial that's really looked at CT in patients who've had or having an acute non-STEMI. So I would not use CT in her. Per the guidelines, it's meant for low to intermediate risk patients with a sort of baseline normal EKG. So upsloping troponins, I would probably go with a cath or nuclear.
Great.
I'll also add the nuclear in her is somewhat surprising. You got only a small amount of defect, and you look at the cath, there's triple vessel disease. So I think what happened in her case, if I were to take a guess, this is not a PET where you can quantify flow. This is probably a SPECT, and the 3-vessel balanced ischemia was underestimated or missed, but that's real life.
Right. Thanks, Dinesh. Let's advance to the next slide. Peter, feel free to weigh in on the imaging side of things, but we'd also love to pick your brain around the lipid piece here. What is this patient's optimal LDL? What you think about the med management and further workup for familial hypercholesterolemia?
So the story is unusually good. Someone presents with what's first exertional chest discomfort, having episodes of rest. So I'm going straight to the cath lab with this lady because of symptoms and because the story is so clear cut. We'll have other cases where things are not at all as clear cut. So I'm starting service on Monday, coming home from the ACC early, and I'll get called to the ED. If I saw this lady in the ED, it would be cath lab right away. The rest pain really is compelling. And, she had pretty good collateralization, which may be one of the reasons that the stress balanced ischemia is also an extremely good thought. So, look, I don't believe in the guidelines. I go as low as reasonably achievable in people like this. My read of the evidence is that lower for longer is better. And, I have patients who have symptomatic CAD who are on triple therapy, that is high-intensity statin, ezetimibe, and PCSK9 inhibitor. And I have one patient's physician whose LDL came back at 6, and he's happy, and I'm happy. And guess what? He hasn't had any recurrent ischemic episodes, which were recurrent for many years, despite milder therapy. So I'm really aggressive. And in this lady's case, the story bites her to take her to the cath lab ASAP.
Great. Thanks, Peter. And so, and I hear what you're saying, the principle I've heard you discuss in other conferences as well, ALERA is low as reasonably achievable for her LDL and ApoB, and what med should she be on, whatever it takes, adding non-statins to get her down to that level. And then we should celebrate a single-digit LDL. And given she had high lipids still on high-intensity statin therapy, which I understand, Dr. Peng, you confirmed she was very adherent to, that really should prompt evaluation for familial hypercholesterolemia. There's a question from the audience, Peter, that I think you would love to weigh in on. The CRP, it was 2.7. What do you make of that? How would you handle that? And Dinesh, feel free to weigh in as well if you'd like after Peter.
Yeah, so she has some inflammatory burden, and that doesn't change my approach to this case at all. I'm going to, shoot the wad at her in terms of preventive therapy. I don't need the CRP. She's inflamed. Sure, she's obese. She has diabetes. But the CRP here is not persuasive at all. CRP can be helpful in primary prevention, someone who's asymptomatic, where you're sort of on the fence. But this is not a case where CRP is going to interest me. A couple things. One is I never send someone to the cath lab, particularly if they're diabetic, without knowing their creatinine. And I don't think, Allison, you're right, I've had the creatinine. Not that we know exactly what to do about that, but I am always jealous of the kidneys when we're about to give a contrast. And I'm sure that our interventionists and your interventionists are very parsimonious with contrast.
Yeah, definitely. Her creatinine was pretty normal, I would say. So we had no reservations sending her over to the cath lab.
And when I say I don't believe in guidelines, this patient would be by a recent AHA, maybe not the very latest, have a goal of less than 70. And in Europe, across the Atlantic, it's less than 55. By the way, I'm very proud because Francois Mach was the author of the guideline with 55, and he was my personal research fellow before he became chief at Geneva. And so the disease isn't that different from one side of the Atlantic to the other. And what that means is the guidelines are just a bunch of people sitting in a room. Some of the best people are excluded because of potential conflicts of interest or apparent conflict of interest. And they generate these numbers. No one's ever done a trial to compare these levels. So guidelines are really important for people who aren't in this audience or on this panel, and for PCPs. And by the way, when we talk, Seth, you're very cavalier about saying that agreeing with me that we should get this patient out of the single digits. But I'll tell you, PCPs are de-escalating. I mean, this is a conversation that I have in clinic. The PCP has told the patient that their LDL is too low, please back off.
I get those messages too. I responded to 2 of those messages in Epic today, that they were told to down titrate their statin or back off therapy. Yeah, absolutely. Thanks, Peter. That's very illuminating. There's so much we could continue to discuss here. Dinesh, did you have any final thoughts on this case before we move on to the next case?
Yeah, just a quick thought on, measuring hsCRP in the acute stages, as Peter mentioned, is not as helpful as in long-term therapy. But, now that's, Dr. Ridker would still argue it's always useful. And I think it is, but I would do it more in somebody where you've gotten the LDL down to 5 or 10, and they still continue to have events. And if you had other options that you haven't used then it can help sway you that there's residual inflammatory risk. I see her a year down the road and she's having persistent events or getting recurrent stents, etc. Then it becomes more of an issue. In her case, at this moment, it's somewhat moot. But just going back to the story, her LDL is 180 to start with, so on statin. So, there's some gaps here. I completely endorse Peter's comment of getting the LDL down to 5 when she's had an event. But her LDL, even according to the guidelines, primary prevention should have been less than 100, which is still too high in my opinion. And there was no sort of imaging done to say, all right, you got a calcium score, you got a CT to define further where you want to take the LDL down to. And I think those sorts of things are coming, and they can really help titrate your treatment decisions.
Yeah, absolutely. Let's see. We did get a couple audience questions in, so maybe let's see if we can tackle these kind of rapid fire and keep momentum going into the other couple cases. So first one, thank you, David Grizel. Why would one do just LPA? Is someone on max statins with persistent high LDL? Wouldn't it make sense to assess ApoB and small dense LDL levels, since it seems likely this patient has elevated small dense LDL in the setting of FH? I mean, I would say we already kind of have evidence that we need to treat lipids more intensively. But Dinesh, Peter, do you want to make any further comments? Do you think you need a small dense LDL? ApoB this woman probably did have, because it is measured pretty routinely at Hopkins. But I don't. Do you feel you need that to make the decision to intensify lipid therapy?
Not me.
Not to intensify therapy, but I think the question is raising, what am I going to do with the LPA? So I'll say 2 things to that. LPA risk is additive. So you can have a normal LDL cholesterol, and you can still have risk from LPA alone. And yes, the ApoB will tell you about that. But I don't think it would be right to assume that because I'm treating the LDL, I don't need to worry about the LPA if I've driven my LDL down to 10.
Right. In her case, the LPA was normal, but an ApoB I don't think was presented, but would have been high had it been, given what we know about her standard lipid profile.
Yeah, the correlation between ApoB and non-HDL cholesterol is probably about 0.98. It's occasionally, I do use ApoB. I'm an ApoB lever. That's the only advanced lipid testing I do. I've never sent any for an MR or gradient gel electrophoresis, although the patients all come to me with all these numbers that are meaningless to me. Just get the LDL down. By the way, in patients with high Lp(a), you can't get the LDL down to 10 because all that's left is Lp(a), and statins actually increase the Lp(a) a little.
Yeah. Yeah, I fully agree. I don't think we need a small dense LDL. ApoB we measure all the time. Frankly, it almost always agrees with the LDL. And we've presented multiple papers that show that, it really ends up changing management in a small fraction of people. The other question was around hypo responders. Do you think she's a hypo responder? Therefore, would she get greater benefit from Zetia and low-dose statins? Dr. Dayspring had a post on this recently. So greater benefit from Zetia and low-dose statin.
So I'll just say to that, the evidence behind high versus moderate intensity statins is good. So we talk about the addition of Zetia to low or moderate intensity statin when somebody's unable to tolerate a high intensity statin. But if they're able to tolerate a high intensity statin, then I add ezetimibe to that. And this lady, because of her very high LDL to start with, is probably going to need multiple drugs, as we talked about. She might need bempedoic acid, a PCSK9. If you really want to get her LDL down to 5, then I suspect you're going to continue the high intensity statin she's on, add a PCSK9, and then perhaps have to add 1 or 2 other agents. So it's a little bit moot in this lady. But the point about using ezetimibe with a moderate or low intensity statin is not a bad idea if your patient's having side effects and you need buy-in to get the LDL where you want it to go.
Great. Why don't we move on just in the interest of time to make sure we get to the other couple cases. So Allison, do you want to present case number 2?
Yeah, definitely. So let me pull up case number 2. So we have a 58-year-old white female with a history of ABNRT, status post-ablation. She had an idiopathic cardiac arrest about 15 years prior, had an ICD placed, and she has this likely arrhythmogenic disease-causing variant gene mutation in CSRP3. And she's coming into the hospital because she's been having this intermittent chest pain for about 3 months, and she notes it's been ever since an episode of COVID. So she has this pleuritic chest pain. There's a bit of point tenderness on her left side chest, mildly worse with deep palpitations, worse with inspiration over the last 3 months. And as I said, she thinks it started ever since an episode of COVID. There's some associated arm numbness. It does radiate to her back. It happened initially only at rest, but recently she's also noted maybe it happens sometimes with exertion. And it lasts for about 5 to 30 minutes at a time. During this 3 months of chest pain, she saw her primary care physician who prescribed Decadron for presumed costochondritis. And she notes this did improve the pain quite a bit, but the pain came back when she tapered off her Decadron. So her family history is notable for a stroke in her father, age 70s. Her brother had an MI around age 60. In terms of her social history, occasional alcohol use, no smoking. Her medications are notable for Nadolol 60 milligrams daily, flecainide 50 milligrams BID, bupropion 300 milligrams daily, desvenlafaxine 75 milligrams daily, and pantoprazole 40 milligrams daily. In terms of her workup, just over the previous few years, she did have a cardiac MRI about 2 years ago. This was mainly due to her arrhythmogenic gene variant, and it was normal. There was no LGE on there. A few months prior to her presentation here, in terms of the workup for her chest pain, she did get a coronary CTA. It noted no significant coronary disease, but the quality of the study was quite limited. She did have a Holter monitor a few months prior. There was an increased PVC burden to 2.6%. And at that time, her Nadolol was increased by her EP and she was started on flecainide. She got an echo during her admission. That was completely normal. Her ICD interrogation showed no events. But while she was in the hospital, she continued to experience these 5 to 10 minute episodes of chest pain. Her high sensitivity troponin ranged from 50 to 80s during these episodes, which was mildly elevated but rather non-diagnostic. And so here I show her baseline EKG. So she has a PVC here, perhaps a Q wave in V1, but otherwise don't see any sort of baseline ischemic changes. And then I'm going to show you her EKGs when she is having chest pain. And so here is one of her EKGs when she's in chest pain. There's quite a few more PVCs, as you can see. And there's notably some ST depressions over in, let's say, V5 through V6, AVF and 2 and 3. And then there looks to be a little bit of ST elevation over in 1 and AVL from over here. And here is a separate episode of chest pain. And again, you sort of see some similar EKG changes. Again, the sort of subtle ST elevations in 1 and AVL, and then some ST depressions over in V4 through V6, as well as 2, 3, and AVF. And so her management, her coronary angiogram reveals mid-LAD severe 90% focal stenosis, followed by about 60 to 70% stenosis. She ends up getting 2 overlapping stents placed, and on follow-up, it seems that she has resolution of her chest pain. Some other labs are measured at this time. Her total cholesterol is 220, triglycerides of 139, LDL of 145, HDL 49, and non-HDL 171. Her ApoB is elevated at 119. Her Lp(a) is elevated at 223. And then her C-reactive protein is normal. So here's our discussion. Dr. Martin, do you want to lead this?
Great, Allison. Yeah, thanks so much. I was trying to respond to some of the questions I saw popping up. I typed the answers to some, but we'll try to get to more as we have time. But Allison, thanks so much for presenting that great second case here with clearly a different presentation of chest pain. So why don't we, as before, start with that piece, that chest pain. Peter, maybe we could start with you this time, then we'll go to Dinesh. What do you make of this chest pain? How would you label this type of chest pain, and what do you think about the initial evaluation?
The clinical presentation was non-cardiac pain. If I saw this patient in the ED or saw a patient in clinic, I would call that non-cardiac. What this proves is that the parsimony principle doesn't always operate. There are a number of atypical aspects to her presentation. It was pleuritic, there was point tenderness, there is a duration up to half an hour. There was no constant relation with effort. So I would have bit the weenie on this one. I think that you continue to have chest discomfort would have prompted further testing. I might not have gone directly to the angiography suite in this one because the clinical story was non-cardiac, but that didn't protect her from having atherosclerosis.
Thank you, Peter. Dinesh, any other thoughts?
No, I think what was done in this case is completely appropriate up front. So, as Peter mentioned, nothing about the chest pain smells like angina. You have somebody who's had previous ventricular arrhythmias and an ICD, so you presume at that point a workup of the cardiomyopathy was done and coronary disease was excluded. So, coronary disease is somewhat low on your differential at this point without knowing the labs and the cholesterol. So the first test, according to the guidelines, and even if you don't believe in the guidelines, a CTA would be completely appropriate because it is a low to intermediate risk category. You don't have a troponin yet in the office. You really don't have a need to draw a troponin in the office with this sort of scenario. What is surprising, though, is that coronary CTA is awesome for picking up any disease at all. So the negative predictive value is where it shines as opposed to the positive predictive value. The PPV is getting better, but the negative predictive value is over 99% with current generation scanners. So yeah, there was some mention that the study was very technically difficult. That can happen if your patient's very obese and moving around, or there's not good opacification, the dye didn't quite get to the coronaries. All of those things happen. But generally, if I read a study and I say there's no coronary disease, I can hang my hat on this, but there's always an exception to the rule. So that's why the angiogram, but I think the angiogram was triggered, as you said, by ST elevations and then that low level troponin. When I saw that first, I'm like, is this an infiltrative disease? Is this amyloid or part and parcel of a cardiomyopathy? And then I saw the EKG. I was like, okay, this is ischemia. We need to work it up more. So then the angiogram sort of, showed that this was run-of-the-mill coronary disease.
So Dinesh, I think that the photon counting CT is going to be really helpful in this kind of case, particularly if it's tech diff.
Yeah. You're absolutely right. I mean, the spatial resolution on photon counting, for the first time, we are matching invasive angiography, so 0.2 millimeters. So you will not miss, soft plaque, hard plaque. It still has the same problems if the patient moves or you got lots of artifact. But generally, in those cases, we will say, I can't rule it out. Please consider something else. I won't say there's no coronary disease because that's what happens. The recipient of that result says, oh yeah, that's been ruled out. So you have to be very carefully of how you word any test result, not just a CTA. If you're not confident at all, then just say so and allow the physician to pursue some sort of other modality.
Yeah, and I'll say
I think you're partly in radiology, so you have the right to hedge.
Let's get into this is great discussion. Let's get into some of the lipid management piece, and this will help address some of the questions that are flowing in, including one around what's the evidence of lowering LDL below 30 that it's beneficial. Some of the key data are led by the Boston group, the Timmy led Fourier trial, but let's dive into some of that. So just as a reminder, in this particular case, her LDL was 145, ApoB was 114, non-HDL was 171, LPA was 223. The CRP was normal. What do we think about these numbers, knowing what we know now? How do we manage her, and what's the evidence around the safety around low LDL?
I can start. I mean, if you look at Glagov and the post hoc analysis from Fourier and Odyssey, it's very clear, not just from these trials, but even the high intensity statin trials, that lower is better. So if you look early days, improve it. Less than 50 still had benefit compared to more than, same amount of benefit compared to an achieved LDL of more than 50. But especially in the PCSK9 era is where we've been able to tease that out carefully. And for every decile of LDL lowering we've achieved, you continue to see benefit. There's no floor at which the benefit stops. So I think that's convincing evidence. And when you look at OCT and IVUS data, you really start to see plaque regression, which we never used to see with statins. It was always plaque progression, and you would slow down plaque progression. But now we're seeing plaque regression once your LDL comes below 30. And at 50, you kind of stabilize it. So I think that's the data there. In her, I would say, quite a bit of the risk is mediated by her very high LPA also, because the baseline LDL was not off the charts. So, I wonder if at least 50% or so of her risk is mediated by high LPA. And so when I'm choosing drugs, I tend to be a little careful. Obviously, I'm going to use a statin, but I might favor a PCSK9 a little bit more because of the post hoc data we have, again, from both the PCSK9 trials showing some reduction and possible some excess benefit in the group that had high LPA.
Okay. Thanks,
So,
Dinesh.
Bob Giuliano's analyses of the low regions of LDL from Fourier was not post hoc, it was pre-specified. And it showed increasing benefit, trend towards increasing benefit, even when you got down to the low double digits of LDL.
Yeah.
And he also led the Ebbinghaus sub-study, which has also had an open label extension, which show absolutely zero cognitive impairment with the super low LDLs, with evolocumab on top of statins. So I think that this is the armor that I use when I'm combating PCPs who want to de-escalate.
Yeah, thanks, Peter. Yeah, and that was a really key Lancet paper that Bob led, and then the more recent extended follow-up data out to 8+ years showing the better outcomes at LDL levels less than 20 with total safety, no increase in adverse events at those levels. It really is quite convincing. Peter, there's another question maybe we could turn to you for. Would you consider colchicine for a few weeks or months, irrespective of the high sensitivity CRP?
Okay, so the colchicine trials did not allocate colchicine on the basis of CRP, so we have no evidence in that regard.
Yep.
And the issue of colchicine in hyperacute coronary syndromes has been clouded by the clear synergy results. I think we should do a whole one of these on colchicine, okay?
Okay.
There's too much to go into tonight.
Okay.
But I would certainly use colchicine in people who meet the entry criteria for LODOCO2 or COLCOD.
Great. Thanks, Peter. There's a question around treatment of someone with normal HDL, normal non-HDL, but high LDL. I think I can say just remember that non-HDL includes LDL. And so the only way I suppose that you could have a normal non-HDL, which typically is classified 30 milligrams per deciliter higher, would be the typical cut point for non-HDL versus LDL. So the only way you could end up with a quote unquote normal non-HDL would be you'd have to have such low triglycerides that your LDL is slightly above the abnormal cut point, and non-HDL then slides, I guess, below it. That's not a situation we see very commonly, but I think it'd have to be someone with very normal triglycerides and someone sort of on the borderline for LDL. Do you have any comments about that situation, Dinesh or Peter?
There's some weird situations, like you get LPX where all your cholesterol measurements are off because you're measuring the wrong cholesterol in the wrong particles. And so there are instances like those where you can get these sort of bizarre situations. But again, you're right. I mean, the triglycerides would have to be very low. Yeah,
and LPX would be reflected in the LDL, non-HDL, and total cholesterol levels on a typical laboratory report. But then if you measure the ApoB, it'll be discordantly low because LPX particles don't have ApoB. Let's see. Maybe we can tackle one more question, then we'll move on to the next case. Let's see. We have a question here. How would you handle a patient with ASCVD event, but LDL within the normal range? Do you start them on high-intensity statin therapy?
So you have to say that average ain't normal. Normal is what animals have, and we have when we were born. What is average, and this was the way in which the laboratories define normal, was average, and it's too high. And if they've had an event, it's too high.
Yeah. So So yes, the short answer is yes. Let's see, Guy, I think there's a number of other questions coming in. I'll allow you to kind of filter through some more that we can push through, but in the interest of time, let's move on to the third case, and then we'll try to tackle as many of the remaining questions for the third case as well as the prior cases as we possibly can. So Allison, let's jump ahead to the third case.
Sounds great. So our case number 3 is about a 55-year-old white male. He's got a past medical history significant for coronary artery calcium, hypertension, and hyperlipidemia. He's referred to our outpatient cardiology clinic for severe hypercholesterolemia and some palpitations. So he was recently seen by his primary care physician due to palpitations. He had a cardiac monitor worn for about 7 days, showed a few runs of NSVT with predominantly sinus rhythm. In addition, he had a recent lipid panel. His total cholesterol was 336, triglycerides 71, HDL 86, LDL 240, and non-HDL 250 while on rosuvastatin 40 milligrams daily. His LPA was normal. His CRP was normal. His physical exam did not show any xanthomas and was largely unremarkable. He had a family history of possible sudden cardiac death and a maternal aunt, as well as a maternal uncle around age 60. He works as a financial advisor, no smoking, alcohol, or other substance use, and is notably quite healthy and walks daily and eats a healthy, balanced diet. So in terms of his prior workup, he did get a coronary artery calcium scan a few months prior to seeing me in clinic. He had a total coronary artery calcium score of about 51, which is 73rd percentile for his age, sex, and race. And here you can see some coronary calcium over in his LAD. In terms of his management, he was already taking rosuvastatin of 40 milligrams, so we started him on ezetimibe 10 milligrams daily. We asked him to get a repeat lipid panel in about 4 to 6 weeks. In addition, we ordered him for an echo, as well as a coronary CTA for further evaluation of atherosclerotic cardiovascular disease, given his elevated CAC score, his episodes of NSVT, as well as severe hypercholesterolemia. He was not bothered by his palpitations. He deferred beta blocker initiation at that visit. So he follows up in about 3 months, and his repeat lipid panel on rosuvastatin 40 and now with the addition of Zetia 10 milligrams shows a total cholesterol of 123, down from about 330 before, triglycerides 52, HDL 79, LDL of 32, down from the 200s, and a non-HDL of 44. His echo was normal, and a coronary CT showed mild non-obstructive coronary disease. So here's our discussion, and Dr. Martin, I'll have you lead this.
Great. Thanks, Allison. Thanks for, again, another very provocative case with quite a bit we can discuss. So why don't we come to you first on this imaging side of things, Dinesh? Would you have ordered additional workup here from the TT, the coronary CTA? What's your reasoning there?
Yeah, certainly the echo. You got somebody with non-sustained VT, you want to rule out structural heart disease, scar, many other things. So the echo is justifiable. In terms of the coronary CTA, I have to say there's not a whole lot of evidence-based recommendations. And the NLA is actually putting together an FH update document. So the calcium score is fairly easy. I think that part, there's more data. So getting a calcium score for prognostication as well as to, guide intensity of therapy. In this patient, if you say the baseline LDL is 240, and if you assume he's taking Rosuva of 40 and you're getting a 40-50% reduction, we're talking about really high pre-treatment LDLs, maybe in the 400 plus range, which classifies as severe hypercholesterolemia, because there's a lot of overlap between heterozygous, homozygous in terms of serum LDL levels. But really what we're treating is how high is the LDL and how many years has it been present for, as Peter mentioned, the cholesterol year burden. And generally, if that's more than 10,000 or so, we tend to be fairly aggressive. So yes, I would lean towards ordering a coronary CTA. I'm trying to rule out ischemia as a cause of the non-sustained ventricular tachycardia. But even if that was not there, I think for somebody like this with very high levels and middle age, you would say, all right, I need to determine a little bit more, especially because there was calcium in the left main. So I would be a little more liberal in imaging in this person.
Great. Thanks, Dinesh. So she, from the lipid standpoint, has the levels that are still quite high on statin therapy. And then there's this, then he has this robust response, it appears, to ezetimibe. Peter, what are your thoughts about this case? Feel free to weigh in on the imaging side, but also curious your thoughts from the lipid standpoint.
Yeah, well, ezetimibe also blocks the ABCG transporters that can sometimes transport the phytosterol. So you have to keep the zebras in mind too. But, Allison, when you say you had no xanthomas, the fellows who work with me in clinic know a patient like this, the exam ain't over until the socks are off. And I always want to get my fingers on that Achilles tendon. In patients like this, and the family history has a couple of premature coronary artery disease. So what I do in this kind of patients, I don't do Simon Broom, which requires genetic testing, but I take the Dutch Lipid Clinic on my phone with the patient and go through it. And this guy might make probable, we don't have his baseline LDL because we got a base LDL after he was already on treatment. But he was in the region that I would suspect genetic dyslipidemia.
Yeah, I completely agree. That sort of massive drop with ezetimibe is almost diagnostic of ABCG5 or 8 cytostrolemia. So I would do the serum levels. And paradoxically, these people, you know, the more healthier they eat, that's what with the usual advice we give them, plant-based diet, their cholesterols never come down. And then there's, you know, we're not advocating this switch to a red meat diet, but that's a tip-off.
Yeah. Thank you. So let's see, we have 15 minutes left. We have some great educational slides here, which I wonder if we could efficiently go through, and then maybe as much as possible, we'll tackle, we've gotten a lot of questions, it looks like, and I'd love to tackle as many as we can. So, so Allison, why don't we go through some of the educational slides? Maybe as we get into the Q&A, we can, I see some of the questions are just, I think they want people want us to pin down on exactly what our LDL goal or lipid goals are, so we can try to do that. But let's maybe tackle these in like 5 minutes or less, and then we can do Q&A.
Definitely. So I'll start with the 2024 National Lipid Association Expert Consensus Guidelines. I don't know if anybody wants to speak to this, but currently, according to the guidelines, it's by ASCVD risk category, which is put into very high risk or borderline to intermediate risk. There's definitions for each of these. And then you have treatment thresholds for your LDL cholesterol, your non-HDL cholesterol, as well as ApoB. Does anybody want to discuss sort of how these cutoffs were decided upon?
I was part of the statement, so I'll just briefly say Dan Soffer and our team was taking into account population percentiles as well as the clinical trial data. This is where ApoB becomes more actionable at lower levels. Greater discordance arises between ApoB and LDL and non-HDL, and so this is where it could lead to just a greater proportion of changes. At the higher end, there's not that same level of action that can occur, but at the low end in a very high-risk patient, it can make a lot of sense. Do we want to say for our patients where they fall, you know, which of these I think what we're saying is we want to go as low as we can. Lower is better. But what's kind of the minimum that we want to get below for the cases that we've taken care of here? Allison, do you want to say what your goals were for these patients?
Yeah, I mean, I think at the very minimum, I would like their LDL-C less than 70 for all of them. But ideally less than 55, as we've talked about, all the data sort of shows that go as low as you can. There's really no lower limit. And so that's sort of what I would hope to implement in my practice.
Great. Thanks, Allison. Yeah, let's keep going.
Okay. Great. And so I think some of these are Dr. Kalra's slides. So if you want to elaborate on sort of what you were thinking in terms of these slides.
Sure. So we talked earlier a little bit about using calcium scores to guide both prognosis and treatment. This was one of the largest databases I came across in terms of using calcium scoring for events. There was more than 600 patients with heterozygous familial hypercholesterolemia who were treated, and they're on treatment. LDLs were in the range of 200 or so. Some had just recently been started on treatment, so it's not all homogeneous population. But what is surprising is two things. So when half of these people, despite having heterozygous FH, had a calcium score of 0, and we're starting to see this, risk factors and phenotypic labels of disease are great, but what is actually happening at the level of the endothelium, as Dr. Libby has spent most of his life researching, is quite germane to what we're treating. Some people, because of healthy endothelium and inability of oxidized LDL to get into that space never develop atherosclerosis, despite all the insults they have, and others do. So I think calcium scoring can be very useful for prognostication. And then at the bottom, I put, so the three curves there show you the higher the calcium score. It's hard for me to see here, but if it's more than 400, which we use even in regular people, not just FH people, then you will see that the hazard ratio is about 10 to 15-fold higher in terms of having events. And from there, we go on to say on the curve on the right shows you, if you just use traditional risk factors, you had an area under the curve to predict an event of, what is it, 0.83. But if you added calcium score, that went up significantly to 0.93. So there's value to risk prediction. The chart at the bottom is what we plan on putting in our NLA FH statement. When do you do a coronary CTA, not just a calcium score? And so this is just all expert opinion. Again, it's commonsensical if you have homozygous rather than heterozygous. So the higher your LDL, that kind of makes common sense. But also male sex, that's been segregated with a high event rate, or somebody with a family history of sudden cardiac death, or additional risk factors like smoking or a very high Lp(a). And then there's some scoring tools like the Montreal risk score. The higher those are, the more predictive you're going to have disease on CTA. And sometimes you'll find people who are asymptomatic and they have tight stenoses. Now, that's a whole different ballgame. What do you do with them if they're asymptomatic? But this helps identify those. So. I think in the interest of time, we'll skip some of these slides. This is the same thing I basically mentioned. CTA can be helpful. This was an interesting one because we had a case of Lp(a), and I thought I'll put on there. That lady to me who had just high Lp(a) and not much else, her LDL was sort of average for the American population, a little bit higher, but quite a bit of a risk was driven by Lp(a). And as we do CTs in people with Lp(a), we're starting to see a different plaque morphology. More soft plaque, especially early on. And that may have to do with the fact that Lp(a) is more inflammatory in its insult, and oxidized phospholipids carried on the ApoB may be the reason that's happening. So we'll see faster progression of these plaques in people who've had CTs, and just more lipid-rich plaque, low attenuation plaques. It's really interesting. I think the rates of MI with the ones that are really high Lp(a) are going to be higher than others who don't have it. And that's still a story that's unfolding, but the CT can really help that. I think that's the only message I had in this slide. And then Guy had me just talk about, why use CT in primary prevention. And it's interesting. Seth was saying, I'm going to Johns Hopkins next week to talk just about this, why use CT for primary prevention. It's an evolving area, and it's, it's not guideline based, but the reason is it's so good. And what you see is you can really quantify. And for a long time, we have basically gone with risk factors alone. And risk factors are like 70, 60% predictive on a population level, but on an individual patient level, we all get fooled. I mean, most of the patients who are coming in with an MI, 70% of them have not had an indication to start a statin the day prior to them coming in. So CT can quantify whole heart atherosclerosis and really hopefully help guide management. So I think I had a couple of slides. This is what Peter alluded to earlier, photon counting CT, just high resolution. The panels on the right show you 0.2 millimeters. So what it does is it really takes away that blooming artifact. Calcium on CT always looked larger than life, so it would cause overestimation of stenosis and overestimation of plaque. And with photon counting CT, we're getting to reproducibility. So, if you want to track disease over time, you need a technique that you can trust, that's not messing up signal noise by 20%. And I think that's where photon counting and the lower radiation doses. Now I can do a CT for 0.6 millisieverts, the same as a mammogram, the same as a calcium score. So if cost was not an issue, why wouldn't I want to know where soft and hard plaque reside and get other features of plaque? Like, is there a ton of lipids in it? Is there pericoronary fat inflammation? Those sorts of things. I don't want to take up all the time. If there's questions, we can address those and we can come back to these. But are there any other questions in the chat box?
Thanks, Dinesh. Yeah, we do have a number of questions. So yeah, appreciate your insights here. And maybe we'll try in the last 5 minutes to tackle some of these questions. One of them I'm going to quickly answer. One of them was around risk of diabetes at low LDL. I'll say there's basically that's what the 488 trial data and other data have shown. There's That's not, there was literally no increase whatsoever with driving PCSK9 inhibitors LDL down to less than 20, down to single digits. There was no uptake, and that was including in the extended follow-up data over 8 years. So there's not a signal there that if you drive LDL down that you produce diabetes. I'm going to read, there's some educational comments, I think, here from Tom Dayspring that I'm just going to read because I think they're insightful. And then there's a couple questions I'm hoping Peter and Dinesh, you can help answer. So Tom Dayspring was asking about the phytosterol levels in case number 2, which I don't believe are available, Allison, but I know, you just met the patient and part of the further workup will be a deeper dive there. But he noted that he felt the patient certainly has ABCG5/8, likely 8 in a Caucasian loss of function, but it might be homozygous loss of function, which means he has xenostelleremia, in parentheses, phytosterolemia. These are tough to pronounce, by the way, and they do not respond to statins very well. So that can be in this particular case, we didn't necessarily know the baseline LDL, what their response was initially to statins. Standard cholesterol assays used for the lipid panel can't differentiate phytosterols from cholesterol. So it might be the phytosterols driving the high cholesterol levels. And indeed, we do suspect that is the case here. So thank you to Tom Dayspring for those comments. There's a couple short questions here. The first one from Nicole Siphone is related to recent trials suggesting that ezetimibe reduces LPA and is currently being studied with CETP inhibitors. I suppose that's referring to the obicetrapib, which is being developed by New Amsterdam. Dinesh, Peter, do you have any comments on that question? They're just asking for general thoughts.
Yeah, so look, what I tell patients with Lp(a), and we should screen everyone for Lp(a) now for a couple of reasons, from cascade screening, and because what I tell my patients, help is on the way. I expect the Horizon study will read out within the next year, maybe this year. That's with pelacarsen, which is the antisense oligonucleotide that lowers handily the Lp(a). The olpasiran study, Oceana, led by Michelle O'Donoghue, is close behind. And while these are secondary prevention trials, I wrote one of my patients today. I'm gonna use it off label as soon as we have it. If it lowers Lp(a), is shown to be safe in the trials and reduces events in secondary prevention, I'm going to extrapolate. So help is on the way. I don't know that ezetimibe lowers Lp(a). Statins raise Lp(a) a little bit, and the PCSK9 antibodies will lower Lp(a) about 15%. That's not enough. According to Brian Ferentz's extrapolations, that's not enough to move the needle in terms of events.
Great. Thank you, Peter. This has been an awesome discussion. I think we're running up against the clock. Guy, I'm going to turn it over to you.
All right, Seth, thank you very much. Thank you, Dr. Libby and Dr. Kalra and Dr. Peng. It's certainly thought-provoking. We have a lot more questions. I wish we can go to extend to overtime, but the lipid panel appears the last Tuesday of every month. Coming attractions next month, April 29th, is Dr. Sam Samikas talking about lipoprotein A. That will not be a CME lipid panel, but certainly worth your attendance if you want to learn about LPA. I want to thank everyone in the audience for joining us. And finally, again, thank you, Dr. Martin, Dr. Libby, Dr. Kalra, Dr. Peng, Dr. Meyerson. And on behalf of myself, thank you all for tuning in. Hope to see you next month.